All right, welcome everyone to another exciting episode of the CNS Journal podcast. My name is Brian Saway, and I'm the fourth year neurosurgery resident at the Medical University of South Carolina. I'm honored to have organized and host this October edition of the podcast. We're fortunate to have a great group of guests joining us today to discuss this newly published article, Digital Biomarkers and the Evolution of Spine Care Outcome Measures, Smartphones, and Wearables. To get us started, I'd like to have our guests introduce themselves. First, we're privileged to have the senior author of the study, Dr. Eric Oermann. Dr. Oermann, do you mind introducing yourself?
Of course. So I'm Eric Oermann. I'm an assistant professor of neurosurgery, radiology, and data science at NYU Langone Health. And I have a background in mathematics and computer science prior to pursuing a career in neurosurgery.
Great, we're glad to have you. Additionally, we have Dr. Christoph Hofstetter, who's joining us today as our guest interviewer. Dr. Hofstetter, do you mind introducing yourself to our listeners?
Hey there. First of all, thanks so much for having me. I'm really excited about this. I'm Christoph Hofstetter, professor at the University of Washington. My interests are in spinal cord injury. That's my basic science interest. And then clinically, I do a lot of endoscopic spine surgery where we have started to implement actually exactly what we're going to talk about, digital sort of, outcome tracking. So I'm super excited about this discussion.
Nice. And lastly, we have our esteemed committee co-chair and veteran Journal Club podcaster, Dr. Rafael Vega. For our new listeners out there, Dr. Vega, do you mind introducing yourself before we jump into the article?
Absolutely. Yeah. I've been enjoying this podcast now for several years. And my name is Dr. Vega. I'm from Beth Israel Deaconess Medical Center in Boston. And my interest, of course, is neurosurgical oncology. But of course, this is a very interesting topic and a great paper. And we're very excited to get it going. So.
Awesome. So thank you all for the introductions. Again, we have a really exciting and diverse group here today to discuss this pertinent topic of technology and spine surgery. I'd like to start off with Dr. Oermann. Could you please give us the background behind the study? What led you to tackling this interesting topic? And then you mind just taking us through some of the key findings of the article?
Yeah. I think maybe some ways the genesis for the study is back when I was a postdoc at Google, I did some work on wearables for Parkinson's disease. And we're specifically trying to see if we could identify the on-off fluctuations of levodopa using Google Watches. And that sort of, in my mind, I guess, planted the seed of the kind of power of mobile devices, but especially wearables, to track neurologic phenomenon. And on coming to NYU and really engaging a lot with our spine faculty, I think the more we talked, I sort of related this experience to talk to them. I think everyone became increasingly enthusiastic about, these are programs that we need to start in our neurosurgery department, not, tomorrow or today, but really we should have started yesterday. And certainly it's something we wanted to launch. And we thought that as a practical aspect of really launching these programs in our department, first, we wanted to just kind of see what was out there and see what other people were doing, which led us to kick off this review.
Awesome. Yeah, I think it was really interesting to read your background and see kind of all of the experience you have with artificial intelligence and machine learning. So I think it's going to be a really interesting discussion we have here. Do you mind just giving us some of the key findings you have from this article?
Yeah. I think that to summarize the thrust of the field and the focus on sort of digital biomarkers is really a push to try to find objective quantitative biomarkers for neurosurgical conditions in general, but especially in this article we focus on spine health. And I think there's been a phenomenal push over the past 10 years on patient-reported outcomes measures, PROs, and trying to capture subjective metrics of quality of life, but also realization that as important as those might be, they're still not objective quantitative measures of quality of life. And maybe even more importantly, this notion that even in the cases where we are capturing those in clinic, either in a qualitative fashion, let's say having patients walk and observing them as part of a neurologic exam, or even in a quantitative fashion, like a timed get up and go test, that we're still not capturing how those neurologic phenomena we're observing in clinic are actually impacting their quality of life in terms of their what we call free living activity. We discussed the manuscript. How is their neurologic deficits leading to a day-to-day impact on their quality of life and their ability to ambulate and achieve things? And that's something that's fundamentally challenging to do as a spine surgeon. We don't go home with our patients. We don't see how they interact on a daily basis. And that's the opportunity that wearables then open up, that ability to assess patients either via active tasks in the environment or perhaps even more excitingly with passive tasks that just record how is their day-to-day life going? How are they able to ambulate? How are they able to accomplish activities? And so it's that continuous passive monitoring that wearables and smartphones unlock that is both so exciting, but also I think maybe the main takeaway of the manuscript is how incredibly heterogeneous that environment is across both the hardware stack in terms of the devices between smartphone vendors and wearable vendors, but then also in terms of the software stack, in terms of the increasingly large number of apps that have access to this data. And I think if anything, it's a very exciting ecosystem for spine surgeons, but also increasingly a very confusing one for spine surgeons and their patients. And the hope is that the review manuscript would try to encapsulate that current state of the environment, maybe make it a little less confusing.
Yeah, thank you for summarizing all of that. Yeah, as a resident, I'm really starting to get into the clinic now, and I'm starting to experience all of the difficulty of getting a really accurate clinical exam and trying to relate that to how the patient is actually doing outside of the hospital and how's their quality of life. So I thought this was a really, really pertinent article to me, myself, and a lot of the residents who I know listen to this. But next up, I would like to open this up to Dr. Hofstetter. Do you happen to have any questions for Dr. Oermann?
Yeah, no, I think I really enjoyed reading your article. We stumbled into this whole field. While you stumbled into the field very scientifically and trying to figure out the on-off periods in Parkinson patients, we stumbled into that field because we innovated spine surgery in a way that patients were not coming back to the clinic appointments. In fact, we saw that only 42% of our patients returned after full endoscopic spine surgery to the clinic appointments. And while we're looking at scientific, objective, and subjective outcomes, in the end of the day, it's very difficult for a surgeon when you don't know how your patients are doing to keep going. And that's something that I didn't see in the article, and I actually wanted to ask you about that because it's like, in order to maintain a system of like being a surgeon and doing all the work that we do, where in your article, what is the impact for the healthcare providers, and where do you see that helping them, and where do you see the role of these new novel tools? Because again, when surgeons and physicians see another EMR and another yet to fill out and more work for us to do, we typically get a cramp in our stomach. So where do you see this helping us?
I mean, I think you actually raised an excellent point where it can help us in terms of letting us have a better insight into our real world outcomes, both in terms of dealing with missingness. Certainly, I think especially for the more minimally invasive procedures, endoscopic spine surgeries, microdiscectomies do tend to be patients that we see them for a couple months in clinic and then they vanish into the world, and we don't really get that long-term follow-up on them. And being able to get that feedback for longer periods of time can be both rewarding or just sort of maybe solve the missingness in terms of loss to follow-up if you have that kind of digital measure for them in the wild. But I think more importantly, giving us the more accurate follow-up. I think we mentioned in the paper, and I know it's one of Brian's questions, is on the Hawthorne effect. And I think it's a very important effect to be aware of, that patients, just by the fact of us formally observing them, will behave differently. And that's certainly, I think we all have those examples of patients who they put on a really great face in clinic, but their families pull us aside and say, hey, look, they're barely functional at home. And that's something that we don't have a great insight into that. And suddenly wearables, which let us, in a sense, journey with our patients into their homes, into their everyday lives, can start to give us insight into that. I think to your other point, though, the user experience of end of thing for surgeons is, how does this, the very nitty gritty, how does this impact our practices? Like, is it another more websites we have to go to, more stuff that gets layered into already very busy clinical appointments, more graphs to look at, more numbers to track? And I think the user experience is a big barrier to, which we maybe don't mention as much in the paper, but certainly a barrier to adoption. And certainly it's also potentially an opportunity. Right? And I do think that the digital offerings, especially in terms of the app ecosystem, that ultimately do see more widespread adoption, will be the ones that really focus on surgeon user experience, maybe a little more so than necessarily on the downstream technology stack. I think all of us would be happier with more rudimentary biomarkers if they were more easily integrated into our practices than maybe something really fancy that we had to struggle to access every visit. And I do think maybe the last point is, as far as that integration goes, and I know this is the approach we're taking at NYU, is really working with our EHR vendor to try to the best of our abilities, kind of deleverage our wearables vendors and get their data into our EHR, into our clinic notes and visits, to make it as seamless as possible to try to lower that kind of barrier to utilization.
I think that's just to respond to that. So I don't know if you know, but at the University of Washington, we have been working on our own project for the last 7 years. We call it, Spine Healthy. And our first generation was exactly as you described, where we collected outcomes, and it was very sort of like, simple. It was basically just like a tool to collect outcomes. And what we saw? It didn't work. If you put an app on the patient's phone, they're not going to do it. And so what we realized then is that, and that's the issue, is, for example, if you watch, for example, Star Trek, they don't land their big mothership on the planets. They have these little sort of, either they beam themselves or they have tiny little spaceships that they land, like lunar landers. And I think the issue that physicians and surgeons have is we are trying with our EMRs, which are the big spaceships, we are trying to land on these little, comets and planets, and it just doesn't work. And we are actually going in parallel here at the University of Washington, both with Epic as well as with our Spine Healthy app. And it has been very interesting to see where one warps in warp speed away, the other one is just stuck in committee work, and it's very, very interesting. But I think during those 7 years, I've realized a couple of things. With this, number one is that the patient needs to have a benefit from this. Nobody's going to even move their finger if they don't have a benefit. And I thought the section of the paper was interesting, where you have the different objective measurements, where they have to walk for 6 minutes, get in and out of the chair for 10 times. That's going to be, you have to reward that somehow. And I think that's going to be interesting. You can, maybe make it a little game, where you just like have them challenge each other or something like that. So I think, but again, anywhere you have to motivate people is going to be a challenge. What we found is the biggest motivator. We published a paper in JNS Spine just I think half a year ago, where we asked them what they want to get out of this, and we asked more than 100 patients, and their responses were, out of the system like this, they want to communicate with a doctor, because believe it or not, right now it's very, very difficult for a patient to get a hold of a physician. For good reasons, because otherwise we would be bombarded. But I feel that a patient that you operate on, I'm sure you've heard, you own a patient that you operate on. So I think for me, a patient that I operate on has a right to get a hold of me. If they want to get a hold of me, they should get a hold of me. That was number one. Number two was they wanted to just see the films of the pathology, and sometimes even intraoperative. And number three, they wanted the physical therapy instructions. So that's what I want a patient get out of it. So I think if we answer these and fulfill them, and some of that was in their paper too, what they want to get out of it, then they're going to do it, right? If there's a benefit to that. As a physician, I don't like it when I spend 5 hours in the OR and then I never see the patient again. It burns me out if I don't see the results of my work. And so for me, being able to see every patient I operate on every day, how they're doing within a fraction of a second, because it's just on my screen, has changed the way I practice medicine. And we have not only done this for myself, but we have now 12 universities where we can now monitor these outcomes, but also learn from each other. And we just had a meeting at the Seattle Science Foundation where these 12 surgeons were together, and we can learn from surgeons like Dr. Telfian, who does those surgeries awake, Peter Derman, who does them in a private practice setting, John Ogunlande, who sets them up in St. Louis at the university. And so looking at these different surgeons and learning from each other with objective markers has changed everything. And I would really say that spine surgery is leading the way in medicine here right now with these efforts. So it's very exciting how we can really very quickly learn from each other and underpin all this with real objective data.
I mean, I think it's really cool that you've built these in-house, with your knowledge as a surgeon. I'd actually be kind of curious to hear what you think in terms about the necessity of surgeons to have a leadership role in this. Whereas you do see a lot of the app ecosystem being really coming out of tech and tech startups, but not necessarily surgeon-led.
I think it's crucial. Again, it's like because if it's not generated by a surgeon, it's yet another thing you have to do. And honestly, every time we turn on Epic, I mean, I just get a cramp. I mean, it is the nightmare of existence. I mean, my inbox has more than 4,000 messages, and I refuse to open it because it would probably give me an instant heart attack. So I'll probably do that the day before I retire. I open my inbox, but again, we are flooded, and there's no way out of there. And so, yeah, all joking by side, I think being a surgeon, a physician is the best job in the world, right? But if you don't see the results of your work anymore, it becomes very tedious. And hospital systems that are paid by administrators in hospitals, that's just not on the priority list. So when I look at the app that the physician generated, and again, the whole group we are very democratically organized in that people see what they want and then we implement it. And so it's only run by what patients want and by what physicians want. And we try to implement that. And just a couple months ago, we saw that, again, this whole ecosystem is only going to work if it makes our lives easier. And so that's what we're implementing right now. And I think that's where the great strength comes in. For example, right now, we are working on automatic, the HPI, producing that for the surgeon, because right now, believe it or not, you're collecting all the prompts. Then you go to the clinic, you have a PDF that is filled out or not. Often you don't even have time to look at it because you have to see 30 patients. And it ends in a trash can, and the patient signed it, filled it up. And so this is, and the reason for that is so, all these different systems that you work on, there's no interest in anybody puts any effort into really, putting all of this together, make it easier, make it more streamlined. I think it needs to be 100% physician driven and patient driven, because in the end of the day, those are the two main players. And I think it's a real opportunity right now, especially with AI components to put into that. I mean, we see that right now is like, well, even the sign up right now is AI driven of our app. So you don't have to type anything in anymore. Just take a picture of your screen and the patient sign up. And so it is really has opened doors and has made it much more fulfilling to be a surgeon, because now you really see what the results of your work are. And the patients love it because they're not left alone and have to call somebody who was hired 5 days ago and suddenly is an expert on my postoperative patients. And so, especially with COVID, that was a very big part in that we didn't have personal anymore. And that's where the whole thing really took off.
I'd actually be curious, what was your experience? Since I don't know if you're a developer yourself, but what was your experience developing that in terms of like the how of getting that operationalized and live in your practice?
I'm definitely a better spine surgeon than I'm a developer. Just to tell you, so I've worked on this for 7 years. We have had, it's entirely sponsored by grateful patients that have used this, and they've been just so excited about this that they have been sponsoring this. And needless to say that right now our version is from ground up built new, the 5th version. And
Wow,
we've
5
made
iterations.
so many mistakes along the way. Is again the first, I mean, just okay, I'll put myself out there. I mean, the first version that we built 7 years ago was a version we used the Apple Health Kit. And basically just put it on the phone and it sort of sent those prompts out. And then I was thinking that, 2 years afterwards, I'll just download an Excel file and that's how I'm going to write my paper. Well, needless to say that, half a year later, we looked at this Excel file and it was empty, because you know what? The, patients, of course, they download it, but then, nobody wants to do that if there's no, communication. People like trees. We like to communicate and we grow in societies. And so, that's a big deal. And I had a super talented, resident James Pound, who has been working on this with me the last year, and he's going to Stanford for a fellowship. And so he realized that, and it was really his idea, is like, kind of healing together, building this community, which again, it sounds, a little, foolish, but I think it really is important. I see that now in the next level too, is where suddenly, again, I learned from Dr. Ray Gadocki at Nashville, at Vanderbilt, how he does his surgeries, how he does his blocks. And if suddenly we can learn from each other and we can talk. And again, my dream is that when I go to a meeting, and we're starting to do this already, that the person on the podium is the best person to speak, has good outcomes, can show the outcomes, and is not there for different reasons. And I think we'll get there, where we can really learn from people that have to share something meaningful and not have to share some, undisclosed, secondary interest, which we all have. But I think, I think there's a real opportunity here.
Yeah, it's amazing to hear the success that the two of you guys are having in New York City and Seattle. I was talking about this paper and some of the different apps and technologies available with some of the my colleagues here in Charleston, South Carolina, and the biggest thing that kept coming up was privacy and patient buy-in. And I think you do discuss this in the limitations section, but I'd like to hear from the two of you, because how did you guys get patients to buy into this? How were you able to navigate that that issue of privacy and making sure that none of their data was going to be somehow used without their permission?
I can speak to my major use as a developer, since we haven't actually deployed it at NYU yet, is at Google. And certainly patient dropout was a tremendous thing. I remember in the first 6 months of us deploying our Parkinson's app, we had maybe, I want to say 70,000 downloads. And of that, about half of the individuals used it once, and more than one data point was maybe a tenth of that. So there's a tremendous dropout. But in some ways, it sounds like, I think Christoph's really addressed that in some ways by this notion of, really focus on the user experience of patients and engaging them as part of a community. And so I'd love to hear kind of his thoughts on that question.
Yeah, no, I think again, it was really a lot of trial and error. I think again, the engagement is actually, when you see a patient in clinic and you're like, hey, we are downloading this app because I want to see how you do after the surgery. You can see their eyes opening. They're like, oh, your surgeon actually who cares who I'm going to do afterwards. And so it's a very positive experience. And so the take rate is in the low 90 or mid 90%. So we published it again in a spine paper and a European Spine Journal where we just published it. I know it was a little bit maybe too late for your paper, but so the take rate is very high because patients don't want to come back to the clinic and you spend 2 hours, they have to park, you look at the tiny little wound, and then they go home. If they're recovering well, it's a waste of everybody's time. And so you telling them that, hey, you don't have, we do virtual follow-ups again in the app, and you don't have to come back. That is enough reason for them to sign up. So there's really almost never a patient who has a cell phone. I think that was a good point, Eric, in your paper too, where you mentioned that 60% of all patients older than 70 have only a cell phone. I think that number is, at least in Seattle, it's much higher. It's like again, 2-3 patients per year that don't have a cell phone. I mean, people are just hooked on that stuff. So it's I think the penetration of cell phones is much higher. In terms of HIPAA compliance and patient confidentiality, I think that's a two-folded question, really. Question number one is who organizes this and who is behind this? I mean, I love it when my hospital administrators come to me and they're like, okay, well, you have a secondary interest, you're doing this research project. And I'm like, so you're working for Epic and you tell me that I have a secondary interest taking care of my patients. So again, everybody has a secondary interest. And obviously, as a surgeon, I just want to have a fun job and know what's going to happen with my patients. So we are only putting in the absolute necessary details into the app. So we don't collect their social security, do not add anything that we don't absolutely need. So there's no addresses in there. There's no social security number in there. There's only a cell phone number in there for recovering any data. The main app does not store any real names. It's just initials because we're not in the end of the day, the big data set is only there for quality improvement and not to point out individuals. So we don't even store that data. So that's one thing. And then the communications are all secured. I couldn't tell you how many bits security, but again, we have the security standards that are required. But again, also adhere to the minimum shareable, information. So only I could see my own patients with names, but they're not showing up in the group. I don't need to see, what Dr. Lynn McGrath's, patients' names are. I have no interest and that's none of my business. So we share only the data that is absolutely necessary to do the job, and the data outside the university, outside my practice, is only important to make it better for everybody. So we very, very much limit what data we enter, and we very much limit to who can see what, and any research effort data is all de-identified. So that's kind of how we've handled it so far.
Awesome. Yeah, I have another question. So a big portion of this paper was related to smartphone apps, and I think there's definitely a lot of promise there, and clearly there's a lot of innovation that's going on. But a smaller, but I would say even just as exciting portion of this paper was on wearable devices. It seems like right now a lot of what is happening in the field of spine surgery and using wearable devices is trying to harness data from technology that wasn't made for patients with spinal pathology, taking information from like an Apple Watch or an Oura Ring or Fitbit. There's nothing out there right now, at least that I know of, that's specifically designed for a patient with spinal pathology. I want to kind of make this just a little think tank here. If you guys could design a wearable device that was perfect for a spine patient, that could get all the metrics that you wanted and would be the most effective device, what do you guys think it would look like? Not to put you all on the spot.
Well, I think it would help you to stop smoking. It would help you to lose some weight.
Yes,
that would be
That's the right answer.
Priorities. And then, in terms of the real answer, then, and actually, I mean, like the funny thing is, like, and Brian, you're going to see that during your career too. Is the most thankful patients are the ones that we encourage to stop smoking, encourage to lose weight before surgery. I mean, it's always worth it to improve health, general health. Now, in terms of technology, and I think that's Eric, I think that's where obviously you are like the superstar here right now to have that insight. We initially, like 7 years ago, we thought about tapping into the accelerometer data of the phones. And we managed it. We were able to do an iPhone 4S, hack in there, get all of the information, no problem. The issue that we saw there is that, once you have all the data, and you have a very nice paragraph in the paper about this, is, like, how do you define a step? How do you define step symmetry? How do you define all of this? I mean, this is all, pre-processed data that we are then afterwards getting. But it's very difficult to do that outside the phone itself because the data quantities that you get So let's say even with a wearable with the best accelerometer that you can do, the data that you would get to your to your database would be gigantic. And I think in the end of the day, that's why we decided to just tone it down and take the stepping data, the geolocation data, the data that is easily available both in the Google system as well as in the Apple system to get that. So at this point right now, a wearable device, again, I don't think it would add that much. The problem is then also then you would have to pay it, if you were to give it to the patient. It's not like a integrated device in a joint or something like that would be meaningful to give you additional data. I think we're at the very beginning right now. And again, so right now we are just with the 5th iteration of the app right now. We're having more and more patients with 1-year follow-up right now. Again, this is how long it takes. And so now we're seeing the limitations. Now, the cool thing about all these data, and as you know, Eric, I mean, like the Apple and the Googles, they store all these data for 6 years. So you can actually now go back, and it's not even, I don't even know how to call it. It's not even prospective. It's like, it's like we need to find a new term for that data because it is just there. You have a patient that you get to surgery and you see how they walked the last 6 years before surgery. They didn't even know you. It's like before they were born. So it's a new, maybe Brian, that's something for you for after this podcast, you come up with a new term for this because it's not retrospective, it's not prospective, it's just perspective. I don't know what you would call it.
Exactly. Yeah.
But that's a cool thing. So it's a whole new array of possibilities. I don't think that wearables right now would add that much, and it also it adds a big barrier to that because you have to get the device, you have to sync it with the phone. Then again, all the technology is like every second in a clinical practice counts. If you sign up a patient and it takes right now with our Spine Healthy app, it takes me 3 minutes to sign up a patient, and it's too long. It's already a barrier that nobody can overcome. So the next iteration should save me time. We'll see if that's true. If you ever invite me back or come to us, then you'll see it. But the next iteration of the app should save time in my clinic. We'll see if I succeed.
What about you, Dr. Oermann?
I can agree. Yeah, I mean, I could agree more with what Christoph said. I think certainly, while I also appreciate the excitement around wearables, I agree with Christoph that I think currently they introduce more limitations, especially in terms of the difficulty of deploying them. If you need to furnish them yourselves, that you're undertaking a huge cost. And then they require different charging apparatuses, maybe different habits for your patients, whereas almost everyone has a smartphone that they're used to charging, used to keeping on them. And while the use of the smartphone over the wearable does introduce extra noise into the data, that makes things like accelerometers suddenly much less interesting because they're much more noisy. When you take one level up in abstraction on the data, like Christoph does, suddenly they become really useful on top of having all those practical benefits. I think if I could, to answer your question, if I could design the ideal device, it would be something with unlimited battery life that people always carry in the exact same spot, that has that rich battery of accelerometers and gyroscopes to maybe get to that more detailed data. I think to me that would be very interesting scientifically. I know that for our Google Watch work, there were some really cool things we did do with the accelerometers, especially looking at postural stability when patients are just standing still. But the value add over ultimately with our wearable work with the watch, we ended up using step count, mean displacement on the geolocation data. Again, kind of those high level features, anyways. And so, I really think that the design principles that Christoph just mentioned are currently the state of the art, and I don't really think they're going to change tremendously in the near future, barring some advances in the hardware and people's habits.
Awesome.
I think to your point, Eric, is what we decided to do is we're collecting those basic data right now, and again, and sort of look for clinical relevance, and then go from there. Because again, there's really not a single study, or people are starting. I think there's one study, the one from Dr. Wang, where they looked at correlation of prompts with stepping. So that's the very, very infancy of that. So we are just right now collecting that data. And so we have now 500 patients with complete proms and stepping data. And so that's where you kind of start seeing what's relevant. And once we have, kind of hunkered down on that and sort of analyzed it, then we're planning to look at more data. But it's just so much that, again, I just remember when we downloaded the accelerometer data, there's just so much information and there's nothing you can do with that. I guess it's just really difficult to analyze, at least for a neurosurgeon who is very, we don't have that type of capability. So.
All right, all. I think we have to wrap up. We're getting close to the end of time. I want to thank all of you guys for coming together and discussing this very interesting topic. Thank you, Dr. Oermann, for this publication and sharing it with the neurosurgical and spine community. And as we wrap up, I, of course, got to mention the CNS podcast activities available to claim for 1.5 CME by visiting the podcast page on cns.org. And please join us next month for the next Journal Club podcast. Thank you, everyone, for joining us, and we'll see you next time.